Nurse.org and Major League Sports teams are honoring nurses with discounted game tickets and once-in-a-lifetime experiences. From throwing the first pitch to riding the Zamboni to on-court recognition, join the fun. Visit nurse.org/nurse night to find a nurse appreciation event near you and grab your discounted tickets today. You're listening to Nurse Converse, presented by Nurse.org, a collaborative podcast amplifying diverse nurse voices. Get ready for a dose of inspiration, a sprinkle of education, and a whole lot of community.
Hello and welcome to the Nurse Converse podcast. I am Courtney T, founder of Nurses of Instagram, DNP, and mom to three littles.
Hi, I'm Courtney D, and I am also DNP. I'm at Court Nurse on Instagram, and mom to one cat after our dog unfortunately had to be put down on Friday. So usually that's my intro, is that we have one big pit bull baby, but he's at the Rainbow Bridge now. So,
I'm so sorry.
Which is kind of relevant to our topic today.
Yes, absolutely. The title of our conversation today is The Talk No One Wants to Talk About, Death and Dying. When we think about standardized nursing and medical education, we typically think about, patho, pharm, anatomy. But have you noticed there's really no standardized conversations or classes that talk about these difficult conversations, how to talk with patients. So that's what we're really going to go over today and why it's so important and how we can approach those conversations as nurses.
Yeah, and it's really interesting you say that, generally we have, when we pick up the phone and call a doctor or something, we have SBAR, and it kind of guides us in how to have that conversation. And when it comes to death, dying, end of life, anything, both acute situations or chronic conditions, there is no format for how to address those conversations with families, with patients at all. So there is kind of that gap in healthcare.
Absolutely. I mean, think about it. How many times have we talked to a patient about a chronic disease that they have and they start to yell at us, like a CHF, for example, and they say, what are you talking about? Like, what's heart failure? I don't have heart failure. I take the water pill, but how dare you?
Yeah. It's funny. I had a patient at rehab that was textbook, like nursing school question. I walk in and he had a container of sea salt on the bedside table. And it was like such a nursing school type question, like you walk into the room and see this. What do you address with the patient? And he just had no idea. He had a huge jar of pickles.
Oh,
and
God.
Either he had no idea or he was, not receiving the education about the sodium restriction. So it's definitely something we see all the time.
Absolutely. So many of them. Getting comfortable to talk about these things early on, both in our careers and in the patient's disease state, is so important. I think we almost feel like we need permission to do so as nurses. Oftentimes, we know that it's out of scope. A lot of the nursing testing, for instance, always talks about scope of practice, what we can and cannot talk about. And so I think that kind of gives, there's a lot of gray area in that as well, because we're like, okay, we have the results. We know the results. When the patient knows it, are we allowed to kind of go into depth into that? Or is that just the doctor's job? But really, it's absolutely the nurse's right to talk about these things once the patient's aware of it. And even if it's charted in their chart, because just like these CHF patients, if it's in their chart, which could be years ago, they've been on Lasix, for instance, for years, but don't realize they have the diagnosis, a nurse can most definitely provide this education and support that they need. And I think it kind of goes hand in hand with the term frequent flyer. A lot of the frequent flyer patients are sincerely just patients who need education and who need to be heard. And so that's all part of our role, of course.
Yeah, I think having the conversation multiple times too is how many times it takes,
Yeah.
Maybe hearing it from one person didn't stick and hearing it from the next person will for whatever reason, especially when it comes to end of life, because so many people have it associated with, giving up or, I'm going to die the next day. If I go on hospice, they're going to take me off all my medications and everything. And so having the conversation sometimes multiple times in, a respectful way, because there is a time and a place to have that conversation. But sometimes people need to hear it multiple times, not just, okay, we checked that box. We talked about hospice. We talked about palliative. They didn't want to hear it. Let's not talk about it anymore.
Yeah, exactly.
Especially being the nurse, you're in one of the most intimate roles, or, even a patient care tech or something, just talking to them about, that doctor was in here earlier, but I was so overwhelmed I didn't really even hear what they said. You're privy
Right.
to so many of those intimate moments that the
Absolutely.
provider may not get when, they pop in and pop out rounding. So having that conversation multiple times.
Yeah, I think that's so true because oftentimes they don't hear it the first time, right? They're overwhelmed, overstimulated, whatever the case may be.
So a little bit about my background. I worked in oncology as my first nursing job, and then I worked in ICU for a very brief stint. I did not like the ICU at all, and then I really fell in love with taking care of end of life patients, both in oncology and the brief time I was in the ICU. So I thought I'm going to be a hospice nurse. No idea what a hospice nurse does, but I just want to work with end of life. So I shadowed a hospice nurse and was like, oh, this is totally for me. And then I did
Mm.
that for about 4 years until I graduated last year. Started working as kind of a primary care integrative health nurse practitioner, and then I do rehab visits. And I taught at a university last year as well. I wanted to do my DNP capstone project on end of life for nursing, undergraduate nursing students in the simulation lab, but they ended up kind of vetoing that project. So I ended up doing something else. But I know you talked a little bit about the field that you work in with palliative and everything. And I was wondering if you
Yeah.
could tell me a little bit more about kind of what you do, what your experience is in the workforce.
I think you might be able to agree with me in this case that we sort of always have these plans as we become a nurse. Like I want to be,
Yeah.
like a peds nurse and I want to deliver babies and whatever it may be. And I'm absolutely somewhere I never thought I'd be. When I graduated, I became a med surg nurse. Then the unit shut down and I went to the respiratory unit. Then I became a float nurse, started the DNP program. And then when I graduated, I went into a subacute care. And so I did that for 7 years. And it was a lot of fixing, 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 right? Or
Mm.
it was fixing, but it was temporarily. And
Mm-hmm.
I always sat and had these conversations with patients. And sometimes, some of the healthcare system can be considered broken in many ways. And a lot of times it made me feel so burnt out to have these conversations. But I felt often that I didn't have support from others, such as like specialists and so forth. And so the things that I was saying was important, but then it was almost trumped by the specialist, and it was focused more on the curative
Yeah.
whenever they went to the specialist. So all the things that I did, it was like, okay, let's try this again and explain how the specialist said this, and it makes sense, and combine it with what I've said, and here's the pathway now. And so it led me to being a palliative hospice NP because what I really cared about was allowing for patients to see the disease trajectory as a whole, as a
Mm-hmm.
life, and not just as medication adjustments, for instance.
Mm-hmm.
It was like, this is a disease that will not go away. This is a disease that will get worse over time. It will be a roller coaster in some, it will be an ongoing decline in the other. And this is what let's figure out what we can do about it and let me support you. And
Yeah.
and really realizing those things. I feel like sometimes I have conversations with patients and I see like a light bulb come on, and it's amazing to see both in their families, sometimes when the patients can't speak for themselves and the patient, and realize that's truly so fulfilling to me. That is so
Mm-hmm.
fulfilling. And the
Mm-hmm.
peace that comes from that, as well as the, very end stages of it all, of course. So yeah, I've never felt so fulfilled in my role, and I absolutely love what I do.
That's how I
Love it.
felt when I was working as a hospice nurse. I was like, do I even want to finish school and graduate? Because I love being a hospice
Oh,
nurse so
yeah,
much.
it's
If there was
amazing.
a full-time way to be a hospice NP, I would find it somehow. But
Ah, too
um
bad you're not over here.
yeah, right. I
Madison, Rhode
still love
Island.
my life. I did
Yeah.
do a palliative care rotation for some clinical hours. I think I did about 80 hours or something like that and had a really good time with it. But obviously, another big thing that people to understand, I think it's important for us as healthcare workers to understand so we can pass on that knowledge, is the difference
Mm.
between palliative care and hospice because
Yes.
they are very different. So, do you want to
Mhm.
touch on that just to provide a
Sure.
little bit of education?
Yes. So, a lot of times nurses might run into barriers, and medical providers, of course, with time. And sometimes, one of the barriers is that you don't have enough time to have all this education, these 15-minute slots when you're having to see 40 patients in a day and whatnot. And palliative care is really who that person needs for the patient. So palliative care is focused on comfort and overall looking at the chronicity of disease and symptom management of disease, and also having the conversations for goals of care overall. Sometimes it could be considered like the bridging to hospice. So when someone is hospice appropriate, which there are qualifications for, they can have these open conversations with the palliative care provider to discuss what are your goals of care. And despite those goals, a palliative care provider is to support that. Whether it be, I want full resuscitation, I want
Mm-hmm.
whatever it may be, it's a supportive role. But there is education to be provided to some of the patients where, a full code might not be actually aligned with their goals of care, unknowingly that they would be on ventilator and so forth. And that's the part of the palliative care provider's role, is to discuss all of those things. And it can be as
Mm-hmm.
simple as, I want to make sure I die home, or I want to make sure, my cat is with me, whatever it may
Mm-hmm.
be. And palliative care is really there for that. Whereas hospice, in order to be on hospice, you must qualify. There are certain diagnoses, and there are certain, along with those diagnoses, it must be end stage. Typically, Medicare says you need 6 months to a year, maybe. You can also graduate hospice, by the way.
Mm-hmm.
And so, with that being said, there's a diagnosis to be met. There are qualifications along with that diagnosis, and a prognosis of 6 months or less. And you would be able to get onto the hospice benefit, and you would have lots of benefits like a social worker. You can have a chaplain. There is a nurse. There is a CNA during the week. Usually it's like 3 times a week. And these visits will increase according to your needs. There's a nurse available 24/7. So despite the nurses visiting you, say once, twice a week, however it may be, there's always a nurse available by phone. And it does not mean do not treat. It does not mean
Mm-hmm.
do not treat at all. There's a lot of stigma related to hospice where people think, okay, it means morphine out of van, you're in bed, you don't speak. It is not like that.
Absolutely.
In fact, if you have the, chronic disease diagnosis that is end stage, you can qualify for all these things, including durable medical equipment that is all covered if it's
Mm-hmm.
related to your diagnosis. And then you can have all of these benefits and support. So even if you have cellulitis and your nurse picks up on a new rash or whatever, there's antibiotics that can be prescribed to you right at home, same day.
Mm-hmm.
So it is never do not treat.
Yep.
It's very supportive. And importantly, it's specific to your diagnosis. So you can be on hospice for heart failure, and you can still go see your oncologist for a lymphoma that you're monitoring, for instance.
Mm-hmm.
You are still allowed to see specialists.
Hey nurses, looking for exclusive discounts? Nurse.org has you covered with deals on everything. Save big on the essentials you need to excel in your career. Don't miss out. Visit nurse.org/discounts for the latest discounts made just for you.
Have kidney failure and still receive dialysis, if
Absolutely,
you need
yeah.
to,
Yeah,
if
that's
that's
right.
what you want. And some people choose to not, and I think it opens up a whole new, set of doors, because all of a sudden you've had this bone mets pain for the last 8 months and
Hmm.
you're in excruciating pain, and you go to hospice and you can receive the fentanyl patch. That is the one thing that helped you, but they were really trying not to, have you on
Right.
opioids or whatever it may be. It just opens up these whole new doors of like, yeah, because you're end of life and the number one priority is comfort, everything else kind of shifts below priority. So I think
Absolutely.
that there's this doom and gloom surrounding end of life and death conversations, and it is something very serious and it is something very difficult. But there's also these little beautiful silver linings everywhere
Hmm.
throughout it, where family isn't so worried about, okay, I need to make sure I give them a shower on this day, I need to help with this, I need to schedule this appointment. All of a sudden you've got this team of hospice, people coming in, caseworkers,
Oh, yeah.
that can alleviate that. So your time is spent with the patient, with your loved one, focused
Hmm.
on that. So I think part of the lack of conversation in end of life is like, and again, it goes back to schools, which I'd love for you to touch back on,
Oh,
what you were
yeah.
talking about with the class, not having
Hmm.
anything, but not being taught about it at all. Like I said, I had worked as a nurse for a couple of years and went to work as a hospice nurse, had no idea what a hospice nurse did. I had no idea what the Medicare qualifications were.
Yeah.
I had no idea what it was. Now, granted, generally speaking, there are people who round and whose job it is to educate and inform on these things. But like we said, as nurses, you're at the bed 12 hours a day with the patient. So you're in those most intimate moments to have those conversations. when that person who pops in for 15 minutes rounding, educating them on what hospice is or end of life, is, they may not be in the right place to talk about that. So I think it stems from a lack of education throughout, not just in school, but in the facilities as well. So I'd love for you to talk about what you had mentioned earlier before we were recording about the class you took.
Yeah. So when I took on the role for palliative hospice, I was led to a course to talk about these difficult conversations. And one of the main things that the teacher, who was also a doc, said is she wanted us to look around, and there were a ton of Ivy League residents and med students are in the room. I think it was actually mandated for them to attend. And she asked them if any of their courses during their schooling, their med schooling, educated them on having difficult conversations with patients, and nobody raised their hand because it's not part of training. It's at all. So you come out into the real world or even you're in residency, that's the real world still, but and you have to have these really tough conversations about these new findings, and nobody knows how to have them. So I think that a
Mm-hmm.
lot of times you don't know, you haven't been trained, they're just avoided, just like confrontation is. It's hard to talk about these things, which brings me to how do we talk about these things? Some of the things
Yeah.
that I've learned and that worked for me is, making sure that it's a good time, like you mentioned. During the hospitalization is difficult, of course, but sometimes we have to do it. And whether that be alone or with family, I think it's important to ask. And most importantly, it's actually asking permission to have the difficult conversation.
I love that.
Yeah, like I want to have a difficult conversation with you. Is now a good time to do that? And would you like anybody here with you
I love that.
before we do that? Yeah, asking permission often allows them to have a little bit more control and
Totally.
knowing what they want, or setting it up for them. Um,
Especially, like you said, in the hospital, when they feel like they have very control over very
yeah.
little, when they go to the bathroom, when they go to appointments, when they go to scans, when they get woken up for their vital signs.
Exactly,
That's very
exactly.
cool. I love that.
Total loss. Once they do provide that with us, it's hearing their background, hearing their story from their words is super important. Letting them talk it out. And oftentimes that's when I find a lot of patients become tearful, sort of thinking back how it all started. A lot of times it brings them back to the worst day of their lives. And letting them express their emotion. One of the best things to do when a patient cries is listen. You don't need to say anything.
Mm-hmm.
Just your presence, maybe a soft touch, and making sure that you're also, sitting in a position where you're sort of open and inviting for them to have those emotions with you. But I think sometimes we fear, like, what do I say? What do I do if they cry? Especially as a new nurse, it's like, what do I do? What do I do? But sometimes you don't have to do much. It's just your presence really being there, showing your support.
One of the things I touched base on in my podcast episode, and like you said, it's not necessarily what you say, sometimes it's how you say it. And I
Hmm.
talked about, things you can do if you have no idea how to take care of an end of life patient. There's still things you can do. You can get the room ready, dim the lights, remove the vital signs equipment,
Absolutely.
write your name on the whiteboard, because that's like super important. And I think, like you said, having those difficult conversations, how you say it, your tone of voice, your eye contact could be
Yes.
huge. Actively listening, and then maybe preparing the room a little bit of, hey, nurses, I'm going to go in, we're
Yeah.
going to have this conversation. It might be fast, it might not be. Please don't interrupt us if at all
Yeah.
possible, because nobody wants that. Nobody wants to be interrupted while they're talking about the worst day of their life, which again is all things that could easily be covered in nursing school, could easily be covered in,
Right.
I don't even think grad school, but certainly grad school. Anytime you're diagnosing and managing, it needs to be part of the diagnostic and management coursework. That's for
I hear
certain.
you.
But I think, yeah, even in undergraduate, like I said, even with patient care techs or aides or anyone who is involved in patient care, some kind of continuing education or
Hmm.
something
Yeah,
done about this would benefit
absolutely.
all of our, because you're privy to death no matter what. If you work in
Right.
the ER, ICU, oncology,
Doesn't matter. Right.
outpatient clinics. I mean,
Yeah.
yeah, I've diagnosed 2 people with cancer, in the year I've been a nurse practitioner. Like it's
Oh, yeah.
it's labor and
It's
delivery.
inevitable. Yes, it's inevitable.
Infusion, you work
Yeah.
in an infusion unit, even if you're not the one coding the patient. Oh my gosh, Sally Joe, who's been coming to see me for the last year for her infusions, passed away. I
Hmm.
hope she was happy. You're privy to it no matter where you work as a nurse,
Oh yeah.
unfortunately and fortunately, because we have such a role to play in these conversations.
Right. Right. And that's where the fulfillment comes in, have the
Yeah.
fulfillment of the role. Yeah, absolutely. Um, yeah, I think that the permission part is so important, and you could reintroduce that permission part too. So even in the beginning, but reintroducing it after they share their story, before you start educating, you want to sort of say, okay, I'd like to talk to you about the difficult, the difficult things now and whatnot. So to sort of, is that okay with you? And again, you're giving them that trust. You're handing it over to them again, making sure they know it's in their hands. Yeah, so I think that the conversations are so important, and it's okay to have them. Someone needs to tell us that, someone needs to tell
Mm-hmm.
us that. And so that's why I feel like this podcast is so important. I hope people hear it. Oh,
Absolutely.
I was gonna say, if you can't, and if it's too much and you may not feel ready for that, and that's okay. You consult palliative.
Mm-hmm.
Palliative consults are everywhere in the hospital, in home care. They can be done anywhere. So please consult the palliative team. Absolutely.
And I think that's something too that nurses should be confident, even if you obviously can't just go put in an order for the consult, really no provider should be upset
Declining.
for you asking to place that
E-
consult. If that's the
Exactly.
case, there is
Yeah.
bigger issues that need to be brought up to,
Yeah.
nursing management or something like
Right.
that. But talking a little bit about resources, I know working hospice, Barbara Carnes, Gone From My Sight Blue Book is something I use all the time, especially at hospice admissions, because it's just, the little book that talks about what happens at end of life, 1 to 2 months before, 1 to 2 weeks
Mm,
before, 1 to 2 days before. And it was a really good touch point to give to patients, because a lot of times they come in and I'm like the hospice admission nurse, and sometimes they don't even know what hospice is yet.
I know.
And it helps them figure out what questions they have that they maybe didn't know they had, so they can read through that. And maybe it's all way too overwhelming day one, even if we're not to the hospice part yet, but just even talking about someone who may qualify for end of life, help them figure out what questions maybe that they have. And then
Hmm.
they'll read that book and they can see, oh man, yeah, my husband, he does do that a lot, and he has been socially
Yeah.
withdrawing, and he hasn't been eating as much, and I thought it was because of this, but maybe it is this. And it can open their eyes. I know when my grandpa went on hospice, I gave that blue book to my dad, and I said the same thing. I said, read this over and let me know if you have any questions. And he was able to read it and kind of see, like, okay, this is dad. This
Yeah.
is dad. Dad has a lot of this stuff going on.
Right. Yeah.
And in those moments, in one ear out the other, it can be so overwhelming. And
Oh
then
yeah.
you get home, you're like, oh my gosh, what did they say? So I think it's really important, like you said, how to have the conversation includes tone of voice, environment, asking permission. It's not always about what
Hmm.
you say, how you say it.
Absolutely. Yeah. Yeah.
Worst case,
I
call in the big guns, put the referral in.
Yeah, honestly, I feel like if you ever have a frequent flyer that's related to a chronic disease, absolutely just
Mm-hmm.
consult palliative, because that patient needs some education, and resources, really, resources too.
Mm-hmm.
Yeah, I think, back to what you were saying about your grandfather. My grandfather was also on hospice, and I remember, I'm sure as you were, family comes back to you a lot for
Yeah.
everything. And it was like you knew like the step-by-step process. I remember getting the phone call. The nurse would just call me and say, we're going to stop his meds today. And like we know what those things mean. And so now the other side of things, you realize like how important every little detail is, and how it's so much more than just like a process, and there's so many people involved. There are so many people involved besides the patient, and all of the barriers. And I feel like sometimes the hardest situations, when the families, people use the term they can't let go, it's really because I feel like it's just so sudden to them, despite being not so sudden to us.
Mm-hmm.
We see it, but they cannot
That's
see it
true.
because they have not been talked to about it. And so it's like, what do you mean my mom's dying soon? What? No,
That's
that's,
true.
it's normal. She's on 6 liters of oxygen, can't walk, and sleeps a lot, but that's just who she is. that's how she's been the past week, and it's just it's so hard. So yeah, these are so important.
Yeah, conversations to patients, conversations to other healthcare workers, because
Yes,
unfortunately there are healthcare workers that are opposed to hospice or
I
palliative.
know.
They, yeah,
I know.
unfortunately, they just won't
So hard.
refer. We've seen him and seen patients die uncomfortably because of, them, but having the
Yes.
conversations with patients, with other healthcare workers, and, with other nurses, but just the general public as well,
Mm-hmm.
you
Yeah.
know, you hear someone say something about hospice, meaning morphine, Ativan, they killed my
Yes.
grandma, whatever it may be,
Yes.
and being like,
Yeah.
hey, I actually know a little bit about this, would now be an
Yeah.
okay time to educate you a little bit on
Yeah.
what kind of actually
Yeah.
can happen, because it's
Mm-hmm.
such a beautiful thing. And
Oh yeah.
and I'm sure you experience this with your line of work, but all the time, we would hear like, I just wish I did it sooner, because all these
All the
resources come
time.
in. No
Yeah.
one says I regret doing it, because you can come off at any
Never.
time if you choose. If you say, hey, I
Never.
woke up and there's a cure for me,
Yes.
for my
Yes.
disease today, we want you to go get it. Are you kidding me?
Or I even say, there could be a serious fall and you see mom's hips out of place. You will go to the hospital. You can still
Absolutely.
go to the hospital. You can panic and say, I don't think I want this anymore. You can absolutely revoke.
Absolutely.
It's your benefit
Absolutely.
at your will. Yes.
Thank you all for listening. I do
Yeah,
have
thank you.
one other Nurse Converse podcast episode where I talk a little bit more about end of life and my experience with hospice and everything, and I love it. But I think this is such
Yeah.
an important conversation to have. It's making me feel fired up and like I want to
Right?
implement another DNP project somewhere along the line. But you can follow me over at Court Nurse for more insight to being a nurse practitioner and a former hospice nurse.
And of course, I'm over at Nurses of Instagram, and I hope to keep this going and keep this fire going with you, Court. The Courtneys.
The Courtneys. I love it. Taking on the world.
Yes.
Perfect. Thank you all so much for joining.
Thank you.
Thanks for joining Nurse Converse, brought to you by Nurse.org. Help us grow by leaving a 5-star rating and review on your favorite podcast platform. Nurse.org supports nurses with career and education tips, life advice, and breaking news. Thank you for all you do and for being you.